Hello, today we're going to be talking about occupational therapy and anorexia nervosa, and this is by Abigail and Rebecca. So the overview is just that we're going to talk about the diagnosis, the International Classification of Functioning, Disability, and Health, which is body structure and functions, activity limitations, participation restrictions, and then we're also going to talk about the role of occupational therapy within the hospital, assessments, interventions, data collection, and the frame of reference.
Anorexia nervosa is clinically diagnosed, and it is considered the restriction of energy intake, which causes extremely low body weight, a fear of gaining weight because one would become fat, a poor self-image, and a lack of recognition of how serious starvation of the body really is. And for females, they lose their menstrual cycle. Some clients may present with anorexia nervosa symptoms, but it should be noted it may actually be avoidant restrictive food intake disorder, which is actually caused by oral motor and sensory processing deficits that lead to low body weight. And this is not the same as anorexia nervosa.
So the ICF components with body structure and function are going to be your value-specific mental functions, sensory functions, neuromuscular, muscle and movement-related functions, cardiac, neurological, gastrointestinal, hepatic, hematological, skin, endocrine, and metabolic. So these are some of the main body structures and functions affected by anorexia. They include values and specific mental functions so that a client with anorexia has emotional dysregulation, which includes depression, low self-esteem, guilt, and lacks impulse control in association with food restriction and too much exercise. Many clients may also have an increased level of alexithymia, which is the inability to identify and describe one's emotions as well as other emotions. It is difficult for them to receive negative comments or emotions, which contributes to the distorted perspective they have of themselves. A person with anorexia may develop sensory dysfunction when they perceive food, including what they think as they see, smell, and taste it. Anorexia affects many parts of the body systems. Malnourishment of the body weakens and deconditions muscles, including the heart. Clients may experience unstable heart arrhythmias, sinus bradycardia, and hypotension. Neurologically, there is atrophy of the white and gray matter. The gastrointestinal system is affected with bloating and various causes of discomfort. The blood is affected with cases of anemia, among other conditions. The skin will break down and dry out. And lastly, the endocrine system is severely affected as the components are no longer synchronized and hormone levels are abnormal. Hypoglycemia and sudden cardiac death are common causes of death.
Routines and habits may include difficulty with the preparatory phase of eating, including the choice of foods and deciding not to eat them due to sensory reasons. Also considered is the obsessive and compulsive habit to exercise. Processing skills associated with anorexia may include lacking the ability to navigate, notice, choose, or initiate due to emotional dysregulation and impulse control. Motor skills can be affected because of the general muscle weakness and dysfunction of the neuromusculoskeletal systems. Social interaction skills, specifically the ability to regulate and express emotions, are all negatively affected as well.
So now another ICF component with the participation restrictions. This will include feeding and eating, social participation, education and work, play and leisure, rest and sleeping, and also shopping. Many occupations are affected that are built upon the body structures, functions, and activities that were previously described. How one participates within feeding and eating is naturally affected, as well as how they relate to other people, how they focus and how they engage in school and work, how they play with others and enjoy their free time, how they rest and sleep, and even how they shop when choosing their food later on.
Multidisciplinary teams in the hospital when treating anorexia nervosa consist of doctors, dietitians, nurses, psychologists, therapists, and others. They all work together for the client's primary goal of weight gain. A client with anorexia needs to nourish his or her body and gain weight while in the hospital in order to be able to return home safely. OT takes part in order to identify the client factors, activities, and occupations contributing to the client's illness so that those aspects of life may be addressed and treated. OT also tries to understand the client in order to promote self-awareness, autonomy, and self-esteem, to practice the daily living skills for certain environments with the client, and also to dutifully measure and help manage the client's energy level and functional capacity.
So the assessments we chose to use for anorexia would be the Children Eating Disorder Questionnaire and the Behavioral and Emotional Rating Scale, the second edition. So Children Eating Disorder Questionnaire is the gold standard for eating disorders. It is appropriate for individuals who are 7 years old or older. The interview will consist of 28 items that ask about one's eating habits the past 28 days and how those habits affect one's daily living. Developmentally, it considers how an adolescent regulates his or her behavior and is concerned about his or her appearance. Now, the Behavioral and Emotional Rating Scale, second edition, is an assessment that works from ages 5 to 18, and there is a teacher form with 52 items, and then there's also a parent and child form with 57 items. These items assess the interpersonal and intrapersonal strengths, the child's family involvement, their school functioning, and the active strength that is present, and the effective strength that is present. So this assessment works to identify the child's levels of behavior and emotions, and this can help the therapist identify what areas may need to be developed within treatment. We also want to consider oral, motor, and sensory assessments so that we can make sure we rule out and avoid the avoidant restrictive food intake disorder.
Intervention with anorexia is challenging because an individual has a mind to act a certain way, occupations to support their behavior, and the physical breakdown of their body as it is starved to death. Therefore, the focus of intervention is on behavior management. It focuses on the psychosocial aspect of the disease and how the adolescent views him or herself. A therapy goal that exemplifies how intervention should be directed is client will improve self-esteem by engaging in an occupation of choice for 45 minutes by time of discharge. Self-esteem within OT is defined as how the person regards his or her capacity to do things and the value he or she ascribes to him or herself. By building self-esteem, clients with anorexia gain self-confidence and the skills to participate in activities that improve their quality of life and thus promote recovery. One intervention that supports this goal is projective art. This intervention follows a compensatory and component-based approach because it allows an individual to express his or her feelings and share their state of mind with others through painting. The point is not about talent, but of self-expression. When producing art, there is no requirement for speaking, but after creating it, the art provides a topic piece that isn't directly focused on the individual, which makes him or her more comfortable to talk. Creating art allows for autonomy and elevated self-esteem. Also, projective art is a good intervention for the first week of treatment because it allows a client who is very weak, fatigued, and unable to concentrate to be able to participate. A second intervention is to help the client discover and identify with a leisure activity they enjoy doing. This takes an adaptive and occupation-based approach because it replaces old habits and roles by introducing new occupations in the client's daily living. Individuals who suffer from anorexia tend to be so withdrawn, wary, and distracted by anxious thoughts that they don't know what it means to have fun. Their time is spent thinking about how to not eat and how to lose weight, so it dominates their time. OT provides a time and place to find occupations that the client may enjoy and supports their recovery, examples of which may include building projects, doing manicures, yoga, and more. The last intervention is poem therapy, which is also compensatory and component-based because it addresses the client's specific mental functions. This form of intervention helps to incorporate self-expression for a client. As an OT, utilizing this type of therapy with a client may help in many different ways. It reduces stress, increases self-esteem, creates a unique form of self-expression. It is also a form that is entertaining and can serve as a hobby for a client. Finding an activity or occupation that matters to the client provides them with a newfound sense of purpose and meaning, thus promoting self-esteem and replacing the original intentions that focus so much on their image.
So for our data collection, it's kind of tricky to measure with mental health because there's not a tangible aspect that you can measure. However, with anorexia, it is known that much of an adolescent's time is spent thinking about what not to eat, how to avoid social confrontation, how to lose weight, and when to exercise. Providing goals of helping a client with anorexia to have a longer engagement within activities can help reduce negative thoughts and work to boost a client's self-esteem. So this chart is made to be able to track the client's time engaged and participating within their therapy session for an activity. It has a column for describing how the various levels of engagement differ, and a second column for the amount of time, and then a third column to report what the client said and did. So as you can see, it's out of 45-minute sessions.
Lastly, the frame of reference identified and applied to this context is the model of human occupation. It foundationally understands humans as open systems, meaning they adapt to environmental feedback that they receive. This adaptation occurs through volition, habituation, and mind-brain-body performance. Volition is how a person is internally motivated in what they value and are interested in. Habituation consists of one's habits and roles. Mind-body-brain performance is how they perceive their environment and respond to it, whether by action or word. OT uses this framework in order to recognize and address the occupational imbalance in a person's life who is anorexia nervosa, and intervenes to reset that balance by adapting the individual's occupational engagement. And these are our references. We thank you for your time, and we hope you were able to learn more about occupational therapy and anorexia nervosa.
Thank you.